Catheter care is a vital aspect of nursing and clinical practice, particularly for patients who require indwelling, intermittent, or suprapubic catheters for bladder management. Each type of catheter has specific indications, care requirements, and potential complications, making it essential for nurses and healthcare providers to understand best practices for insertion, maintenance, and monitoring. This comprehensive guide explores the principles and practicalities of caring for indwelling urethral catheters, intermittent catheters, and suprapubic catheters, with a focus on patient safety, infection prevention, and quality of life. Indwelling urethral catheters, also known as Foley catheters or IDCs, are inserted through the urethra into the bladder and are designed to remain in place for a period of time. They are commonly used for acute urinary retention, monitoring urine output in critically ill patients, bladder irrigation, administration of intravesical medications, and sometimes for quality of life reasons, such as in end-of-life care or chronic neurogenic bladder. Indwelling catheters are also used postoperatively or after trauma when short-term or long-term bladder drainage is necessary. The decision to insert an indwelling catheter should always be based on clinical need, and daily assessment is necessary to ensure the catheter is still required, as prolonged use increases the risk of complications. 9. The insertion of an indwelling catheter must be performed using strict aseptic technique and sterile equipment to minimize the risk of introducing pathogens into the urinary tract. Hand hygiene is essential before and after catheter care. The appropriate catheter size and material should be selected based on patient factors, with silicone catheters often preferred for long-term use due to their lower risk of incrustation and allergic reactions. 5. The catheter is connected to a closed drainage system, usually a leg bag during the day and a larger drainage bag at night, to reduce infection risk and allow for accurate monitoring of urine output. Routine care of an indwelling catheter involves regular assessment of the catheter and insertion site. Nurses should check for signs of infection, such as redness, swelling, discharge, or foul-smelling urine, as well as for blockages, leaks, and patient discomfort. 2. The catheter and perineal area should be cleaned daily with soap and water, avoiding harsh antiseptics that can irritate the skin. Maintaining a closed drainage system is crucial, and the drainage bag should always be kept below the level of the bladder to prevent backflow of urine, which can introduce bacteria and increase the risk of infection. 2. The bag should be emptied regularly into a clean receptacle, and care should be taken not to touch the drainage spout to any surface. Catheter-associated urinary tract infections, CAUTIs, are the most common complication of indwelling catheter use. They can result in increased morbidity, prolonged hospital stays, and higher healthcare costs. 4, 6, 8. To reduce the risk of CAUTI, catheters should only be used when absolutely necessary and removed as soon as they are no longer required. Other complications include catheter blockage due to incrustation or sediment, urethral trauma, metal stenosis, bladder spasms, and a negative impact on quality of life, such as discomfort, reduced mobility, and social isolation. 2, 4, 5. If a catheter becomes blocked, flushing may relieve the obstruction, but replacement may be necessary if flushing is unsuccessful. 4. Intermittent catheterization, also known as clean intermittent catheterization, CIC, or in and out catheterization, involves the periodic insertion and removal of a catheter to empty the bladder. This technique is often used in patients with neurogenic bladder, urinary retention, or after certain surgical procedures. Intermittent catheterization can be performed by healthcare professionals in a clinical setting using sterile or aseptic technique, or by patients themselves at home using a clean technique. 3. The clean technique involves standard hygiene measures, such as washing hands and cleaning the genital area, and the use of a disposable or well-cleaned reusable catheter. The main advantage of intermittent catheterization is the lower risk of infection compared to indwelling catheters, as the catheter is not left in place. However, patients and caregivers must be thoroughly educated and trained in the correct technique to minimize the risk of introducing bacteria and causing trauma to the urethra. Catheter size and frequency of catheterization are determined by the treating urologist, and adjustments may be needed based on patient comfort and the presence of strictures or other anatomical challenges. 3. For some patients, a self-dilation program may be recommended to maintain urethral patency after surgery or to prevent stricture recurrence. Complications of intermittent catheterization include urinary tract infections, urethral trauma, bleeding, and discomfort. These risks are minimized by using appropriate lubrication, gentle technique, and strict adherence to hygiene protocols. Patients should be monitored for signs of infection, such as fever, chills, cloudy or foul-smelling urine, and should be encouraged to report any pain, bleeding, or difficulty passing the catheter. Regular follow-up with healthcare providers is important to assess technique, review catheter supplies, and address any complications or concerns. 3. Suprapubic catheters, SPCs, are inserted surgically through the abdominal wall directly into the bladder, bypassing the urethra entirely. SPCs are indicated for patients who cannot use a urethral catheter due to obstruction, trauma, failed catheterization, or long-term management needs where urethral catheters are not suitable. 1. 5. They are anchored in place by an internal balloon and can be used for both short-term and long-term bladder drainage. SPCs are commonly seen in urology units, community health settings, and residential aged care facilities. The care of a suprapubic catheter requires adherence to sterile technique and regular assessment of the catheter site to prevent infection and other complications. 1. 7. The insertion site should be inspected daily for signs of infection, such as redness, swelling, discharge, or pain. The area should be cleaned with mild soap and water, and dressings should be changed as needed according to facility policy. The catheter should be secured to prevent accidental dislodgement, and the drainage system should be checked regularly for leaks or blockages. Changing a suprapubic catheter is considered a high-risk procedure and must be performed by a qualified clinician using sterile equipment and aseptic technique. 1. 7. The frequency of catheter changes varies but is typically every 4 to 6 weeks, depending on patient factors and local protocols. 5. Before changing the catheter, it is recommended to instill a small amount of sterile water into the bladder to reduce spasticity and help align the stoma for easier insertion. 5. If the SPC falls out or cannot be reinserted, immediate medical attention is required to prevent closure of the tract and avoid the need for further surgery. 5. Potential complications of suprapubic catheters include infection, blockage, leakage around the catheter, bleeding, pain at the insertion site, and autonomic dysreflexia in patients with spinal cord injuries. 1. 5. 7. Autonomic dysreflexia is a medical emergency characterized by sudden high blood pressure, headache, sweating, and flushing, and requires immediate intervention. Other complications include catheter displacement, balloon deflation failure, and difficulty with removal. If the balloon does not deflate, additional sterile water may be instilled to dislodge debris, or the tubing may be gently squeezed to break up crystal formation. 5. Persistent problems should be referred to a doctor or emergency department. A comprehensive catheter care plan is essential for all patients with urinary catheters, regardless of type. 1. 7. The care plan should document the indication for catheterization, expected duration, catheter type and size, and specific care instructions. Regular assessment and documentation of the catheter and insertion site, urine characteristics, and patient symptoms are critical to early identification of complications. Patient education is a key component of catheter care, including instruction on hygiene, signs of infection, proper handling of the drainage system, and when to seek medical attention. 2. 8. Cultural, religious, and individual considerations should be respected in catheter care, including the use of interpreter services and engagement with Aboriginal health workers or liaison officers when appropriate. 1. 7. Shared decision-making with patients and their families supports autonomy and ensures that care aligns with the patient's values and preferences. Nurses and clinicians must stay up to date with best practices and participate in regular skills assessments to ensure safe and effective catheter management. This includes understanding the indications for catheter use, recognizing and responding to complications, and knowing when to escalate care or refer to a specialist. Infection prevention is the cornerstone of catheter care. This includes strict hand hygiene, use of sterile or clean technique as appropriate, maintaining a closed drainage system, and ensuring adequate patient hydration to flush bacteria from the urinary tract. 2, 6, 8. Catheters should be used only when absolutely necessary and for the shortest duration possible. Early removal of catheters, when clinically appropriate, reduces the risk of infection and other complications. 6, 9.